Everybody, sorry I can't see people, but I'm very grateful for the invitation to present a webinar about Wolfram syndrome and present some research of a large number of colleagues across Europe and America and Japan who've supported this. So what I hope to cover is a brief background to the syndrome. I'm going to concentrate then on some clinical presentations and what we've learned about those over the last 10 years, an update on what we understand for the genetics, some of the current management that we're doing in our clinics in Birmingham, our current understanding of the pathophysiology, and then briefly about what ongoing research and clinical trials are in the pipeline. So I'll start really with the classical picture, which hopefully many people in this webinar will be familiar with. Peter and Kelly are really an example of classic Wolfram syndrome, first two children that I saw with this condition many years ago, presented with typical osmotic symptoms in the first 10 years of life, with weight loss and lethargy, raised glucose, no ketones, and in those days they were assumed to have type 1 diabetes and treated with insulin. Unfortunately, within 5 or 6 years, they were finding that they were losing their color vision, and so they were referred to an ophthalmologist who diagnosed optic atrophy. And you can see in the photograph on the right hand side the picture of them roughly at the time they were diagnosed above, and then below about 10 years later on holiday with their white sticks, and now they have significant visual impairment. As adults, and I'm still in contact with the girl here, they developed imbalance, cranial diabetes insipidus, bladder problems, swallowing problems, and some brain atrophy, and it demonstrates the long-term natural history of this condition. This was first described by Dr. Wolfram in the Mayo Clinic about 80 years ago now, in a large extended family of 9 brothers and sisters, of whom 4 had blindness due to optic atrophy, diabetes insipidus, mellitus, and deafness. And soon after that, the acronym was coined DID-MODE for those 4 key features. But in actual fact, if you go back in the literature, you can see that the combination of diabetes mellitus and optic atrophy in young people was actually described earlier than that in an ophthalmology clinic in Berlin. So Wolfram syndrome now is recognized to be greater than just DID-MODE, because neuropathic bladder and neurodegeneration do seem to be fundamental parts of this classic pattern. It's something like 1 in half a million, but if you look at a children's diabetes clinic, it's probably about 1 in every 150 children in a diabetes clinic. So it's not so rare as you might imagine from that. The inheritance is mainly autosomal recessive, but we now know that you can get dominant forms as well. And indeed, there are now 2 genes. So the gene that's predominant in Europe are mutations in the WFS1 gene on the short armor chromosome 4. And then patients have been described in Morocco, Italy, and parts of Palestinian Arab populations of a second gene on the long armor chromosome 4 encoding a different protein. But what we can say is that if you have mutations, you will find mutations in over 90% if children develop diabetes mellitus and optic atrophy under 16 years of age. And the underlying pathology seems to be related to endoplasmic reticulum stress, or an unfolded protein response. The natural history on the left, as we understood it some years ago, was that pretty much everybody would get DM, diabetes mellitus, OA, optic atrophy in childhood. About 2/3 would get cranial diabetes insipidus, and maybe half sensorineural deafness, and then a smaller number with renal problems, neuropathic bladder, and then neurodegeneration occurring in adulthood. But work by Annabelle Chassinot, Véronique Paquis, and others, very nice work presented in the Annals of Neurology on French families, showed that actually, if you look hard enough for it, you can detect neurological problems in childhood, particularly issues around balance and proprioception. And indeed, the bladder issues are for renal here also occur significantly in childhood, and we've now seen that with more detailed characterization as well. So I've described there the classical form as we understood it of Wolfram syndrome in the literature. It can also present with neonatal diabetes without other features there, been described very nicely by Andrew Hattersley's group and Sarah Flanagan in Exeter. There are some forms of congenital cataracts, isolated cataracts, that have been described due to variants in the Wolfram gene, dominantly inherited non-syndromic low-frequency deafness. So the Wolfram gene is also a recognized gene for non-syndromic deafness. And then various other combinations of partial Wolfram, such as adult onset optic atrophy deafness, psychiatric disorders. The second Wolfram gene is associated with platelet disorders and gastrointestinal bleeding. And then, of course, some Wolfram variants have been associated with common type 2 diabetes in the population. So this is a really interesting spectrum of disorders that's much broader than we understood even 10 years ago. And there's one example on the right. This is a patient seen in our adult clinic here. He developed childhood diabetes at the age of 13, insulin treated, and then diabetes insipidus, age 16 years of age, treated with desmopressin, and then developed bladder dysfunction, but no vision problems, no optic atrophy, and no deafness. And he's been found to have mutations in the Wolfram gene. You can see here as well, or at least one nonsense and one missense mutation. So the clinical spectrum of this disorder is much broader now than we used to understand. Complications that I've seen that have really quite concerned me, and I want to give two examples. One is relating to the bladder, and this is a child that we saw in our clinic a couple of years ago now, diagnosed with diabetes at age 7, optic atrophy aged 8, so fits the diagnostic criteria, and then long-standing nocturia with frequency. Parents were first cousins and was found to have mutations through an optic atrophy gene panel was to found this. And there are other social issues there as well. When we saw this child in clinic, she had smelly urine and had a urinary tract infection, but she'd already got evidence of raised creatinine and some signs of impaired renal function. She got some sensation to passing urine, voided 75 mils on urodynamics, but the post-void scans showed that she retained a volume in her bladder of almost just over half a litre, and the ultrasound scan showed a large flaccid bladder with evidence of obstruction and megacystis. She went on to have intermittent catheterization. So what this shows here is a urodynamics flow pattern of the urinary outflow for somebody who's got delayed micturition. And what you can see, a nice bell-shaped curve, but you can see quite a delay before micturition is established to actually deliver that. And that's a pattern that's sometimes seen in the early stages of bladder dysfunction in Wolfram syndrome. Other patterns that you can see is this staccato urinary flow, where patients stop and start, and this is partly from an overactive or sometimes poorly contracting bladder, and this staccato pattern is seen in quite a few children. Now, the pattern that this girl had was different again. So look at this. So this child on urodynamics, here we are, here's the time on the x-axis, and you can see almost unable to get any urine out, and then this small dribble out here after about a minute or a minute and a half. So a really poorly contracting bladder. And the concern here was that this obstruction was causing megacystis and impaired renal function. So that came on within about 6 weeks or so after her initial ultrasounds at that point. And I think this megacystic pattern causing impaired renal function is a really important complication to note and to be aware of, because of course it can be treated by relieving the obstruction through intermittent catheterization or other mechanisms. The second complication I wanted to present that we've seen is bulbar palsy or choking and swallowing episodes. It's mainly adults, but we have seen it in some children. So we have some teenagers, 16, 17-year-olds, who've got a history of choking with the food, swallowing difficulties. Sometimes it's liquids as well as solids, and they're obviously at risk for aspiration pneumonia. It can be associated with a loss of sense of taste and smell. And of course, the cranial nerves for these sensory areas also come off the midbrain. And it can be associated with central sleep apneas. And of course, the sleep or respiratory system, again, is in part of the midbrain. It seems to be secondary to brainstem atrophy, which in some patients, for reasons we don't understand, occurs younger than in others. And these are patients who clearly need a swallowing assessment and a speech and language assessment to address that. And here on this MRI scan, you can see from our clinic a healthy coronal view of a healthy child seen in Birmingham Children's Hospital on the left-hand side, and a similar aged child on the right-hand side with Wolfram syndrome. And I think you can see that the differences are quite apparent. On the left-hand side, you can see a healthy size of a midbrain and the cerebellum, and not very big fluid-filled CSF spaces in between. On the right, you can see how the midbrain has really become atrophic, quite a narrow area of the midbrain here, and the pons is very atrophic. And then the cerebellum is quite a lot smaller with quite large fluid-filled spaces in between. And interestingly, I think there is still a posterior pituitary white spot in that patient who doesn't yet have diabetes insipidus. Other features, diabetes insipidus tends to be, well, it's always cranial, but it tends to be partial, and it responds very well to desmopressin. And we tend to diagnose that from an early morning paired fasting urine and plasma osmolarity and sodiums. This deafness is usually high tone, but in some autosomal dominant forms, it seems to be a low tone deafness. Some patients require hearing aids, but many manage one-to-one conversations. It's in crowded rooms and busy spaces that they have difficulty. The optic atrophy does seem to be progressive, and it does lead to severe visual impairment in 8 to 10 years in many. Although saying that, in our adult clinic, we have at least one affected lady, age 62 now, who's still got quite useful vision. The neuropathic bladder seems to go through stages of initial bladder overactivity, which might respond to anticholinergics and other agents, and then a period of underactivity and flaccid distension, a bit like a balloon that's been blown too far, and then it's then unable to contract. And one interesting area now is to see whether or not, if one can treat diabetes insipidus effectively early on, one might reduce the urinary outflow and hopefully relieve the pressure on the bladder and it progressing along this route. The neurodegeneration, as I said, can present with swallowing and choking episodes and also ataxia older on and sleep apneas, but it doesn't seem to occur in everybody. So it's not an absolute given that everybody gets every complication. All patients all seem to complain of tiredness, and it's difficult to know, is this part of the condition or is it part of the secondary to the symptoms such as nocturia and the diabetes. But quite a lot of patients do get psychological complications, particularly depression and occasionally bipolar disorder as well. And this definitely seems to be part of the syndrome altogether. Most patients don't seem to have cognitive impairment. So there doesn't seem to be any association with learning disabilities because of the Wolfram syndrome, although it might be there for other reasons. The genetics of this, so probably about 95 to 98% of Wolfram is caused by mutations in the WFS1 gene, and this accounts for almost all European patients. It encodes a protein, the Wolfram protein, that localizes to the endoplasmic reticulum, which, as you know, is an organelle in the cell, essentially a protein factory or a protein folding factory. And of course, it's widely present in pancreatic beta cells, where the cells are obviously making lots of insulin protein, and also in neurons, of course, where the cells are making lots of neurotransmitters. The Wolfram 2 gene, present in perhaps less than 2% of the cases described so far, largely have been in a Jordanian Arab population, but also more recently in patients from Morocco and indeed Italy. It also seems to localize to the endoplasmic reticulum in its mitochondrial interface and may well have a role in calcium homeostasis as well. There does seem to be a relationship with the gene variant that you have and what sort of disease this is. And a very nice paper published from Andrew Hattersley's group, DeFranco et al., looked at this a couple of years ago, really classifying those mutations which seem to have partial features, such as diabetes only, hearing loss only, cataracts only, or optic atrophy and hearing loss, and some of the variants which seems to have a milder series of symptoms and seem to be inherited in a dominant fashion. And then the more classic ones that we've been talking about, the classic Wolfram syndrome, with a whole range of mutations, often loss of function, that seem to be inherited in an autosomal recessive fashion. And then again, some dominant ones, which seems to be neonatal diabetes, so very early onset, and some syndromic forms of hypotonia, a few mutations there, which again seem to be dominant. So there does seem to be a genotype-phenotype correlation here, but it's so interesting as to why we should have different patterns of inheritance from variants in the same gene, different parts. partly because of this, and partly because if you say somebody's got Wolfram syndrome and they Google it, they immediately look at the classical form, and it's just absolutely devastating for families to do so. Elizabeth Tranebjijk and others, other colleagues in Denmark and Scandinavia, are moving really towards a gene-based classification of these disorders rather than the Wolfram term. So perhaps we should be trying to move away from the term Wolfram and say WFS1 disorder for the classic form. So at the top here is what we're still calling Wolfram syndrome, 2 mutations, plus diabetes mellitus and optic atrophy, any age of onset, or the classic features, diabetes and optic atrophy, and 2 others. And then WFS1 gene-related disorders, the recessive form, which seems to be a milder form of disease with diabetes or optic atrophy, or indeed none of those other features. And then WFS-related disorders, the dominant form, dominantly inherited WFS1 mutations. And perhaps we need to move towards this gene-based way of classifying the diagnosis to protect patients from thinking that everybody is going to have the same features as that classical Wolfram syndrome. So what do we know about the pathophysiology of this disorder now? As I said, the 2 Wolfram genes encode proteins that are localized to the endoplasmic reticulum, and this organelle functions as a secretory pathway, secreting proteins. It folds proteins, post-translational modifications, and it assembles them, very important for that. It also acts as a calcium store for the cell, and calcium is obviously a major signaling ion within the cell. And it's also a site of a lot of lipid synthesis as well. So there's a lot of multiple functions from here. Very nice review of endoplasmic reticulum stress disorders causing monogenic disorders, published by Fumi Arano's group, Dr. Stone and others, earlier on this year, shows quite a, I think, quite a helpful cartoon here. So on the left-hand side, you can see the endoplasmic reticulum lumen, and these are insulin, so say of the beta cell, and these are insulin peptide chains being folded within there. And there's this pathway here which leads to the unfolded protein response if that cell gets stressed or has too much pressure to make too much protein. Now that consists of several parts. The PERK on the left here, tightly bound to BIP protein, which keeps it inactivated. And while that's inactivated, it allows the EIF2 complex on the left here to work and to drive protein translation. And then further across here, you can see BIP binding to ATF6, another component of the unfolded stress response pathway. Now, the Wolfram syndrome protein here, WFS1, acts as a negative regulator of ATF6, and it stops the unfolded protein response pathway being activated unnecessarily and causing cell damage. It also acts as a controller of calcium ions entering into the calcium store in the endoplasmic reticulum. So it seems to control ER calcium flux. And just to its left here is the protein product of the second Wolfram gene, CysD2, which acts as a negative regulator of the cytosolic protease, calpain, which needs to be switched off, otherwise it sets off apoptosis within the cell. On the right-hand side, here, what you can see in this case is that under conditions of endoplasmic reticulum stress, if there's too much demand on the endoplasmic reticulum to fold proteins, and errors occur so that misfolded proteins build up, such as misfolded insulin, BIP dissociates from the unfolded protein response genes PERK and IRE3B1, and it binds to the misfolded proteins to help clear them. That then initiates a downstream unfolded protein response so that PERK gets phosphorylated, dimerizes, and then sets off the downstream response to actually shut down the EIF2 complex and attenuate translation, taking the pressure off the endoplasmic reticulum in the cell. At the same time, IER3P1 gets phosphorylated, moves to the Golgi, and helps transport ATF6 to the Golgi, where it dissociates, forming free ATF6 and initiates downstream pathways to as part of the endoplasmic reticulum stress response. That includes activating CHOP, which is a protein on the apoptosis pathway, and if in overdrive and uncontrolled, leads to cell death and apoptosis. In the absence of the Wolfram syndrome protein here, absence of that, there is no break on this ATF6 dissociation, which can freely occur, leading to an uncontrolled downstream response and uncontrolled apoptosis. And presumably, in Wolfram syndrome 2, in the absence of this, there's no break on calpain, the protease, and so that calpain itself also initiates CHOP-released apoptosis. So this is the current thinking about the mechanism of cell death in Wolfram syndrome, and it leads potentially to therapeutic strategies to try and treat this. One strategy might be molecular chaperones to take over the work of BIP here and actually bind to these unfolded protein response genes in the membrane here, and to try and deactivate them at that point. Calcium channel blockers, such as verapamil, which would hopefully try and control the release of calcium from the endoplasmic reticulum and stop it activating calpain-2 here. And cell cycle inhibitors that will actually try and stop the cell going through into an apoptosis mode and stabilize it at a growth phase to try and stop this CHOP action here. Okay, I'm going to leave the pathophysiology now and then go on a little bit to the management issues next as part of this. Other features that need addressing in some adults, although not all, include hypergonadism. We talked a bit about bladder instability. Some patients also seem to have bowel incontinence, which may be secondary to the bladder instability, of course, or it may be an autonomic nervous system degeneration as part of this. A gradual loss of balance, and of course anxiety and mood disorders, intrinsic to the syndrome, but also perhaps secondary to some of the other horrible physical manifestations of the condition. So the MDT team that we've put together incorporates endocrinology to look at the hormonal aspects, medical genetics, neurology, MR imaging to try and understand what's happening in the central nervous system, psychology support, urodynamics and urology to try and help this really bad problem with the bladder. In our children's clinic, play therapy, because these take a long time, these appointments, gastroenterology relating to the bowel problems, and then of course family and social support. So it's taken a lot of work to pull these together. We've been very fortunate. One good thing that we've had is that the National Health Service pays for about 70 or 80 highly specialized services across the country for rare diseases. And one of these, thankfully, has been Wolfram syndrome. And this has allowed us to have set up a specialist centre in Birmingham where children and adults to the adult clinic can come once a year to see all the hospital specialists on one visit with individual appointments. So families tend to come on a Sunday afternoon and they have investigations on the Monday and see the specialists on the Tuesday and then go home. And at the end of that, they have a multidisciplinary clinic letter put together with the specialists agreeing a plan for the next year, used to support the local health teams from whichever part of the country they're from. So on the visit, have an MRI scan, see our pediatric or adult neurologist, have an endocrine and a diabetes review, have molecular genetic testing if it's not already been performed, see an optometrist for visual function tests and an ophthalmologist for advice about vision aids, urology and urodynamics, and of course genetics and genetics counselling. And then with the support of the children's charity Well Child, which has been fantastic, having a family liaison officer to support the families to get to the clinic, to help them with accommodation while they're there, and to help fund their travel as they go home again. And then with a nurse specialist and a research nurse to help recruit them into research studies or tell them about other initiatives that are going on. Just looking at some of the individual aspects of this that we've had, very nice paper from my colleague Dr. Julia Rohaim in Munster, published a few years ago now, reviewed about 50 young people and children and adults with Wolfram in Germany, and was able to compare the type of diabetes in Wolfram syndrome with that in type 1 diabetes. And what you can see based on her population of 50 patients, older here as well, and comparing with over 24,000 patients with type 1 diabetes from the DPV registry, the age of onset of diabetes in Wolfram seems to be a bit younger than that in type 1. There's a lower presentation of diabetic ketoacidosis, which perhaps suggests that there may be a bit more residual insulin secretory capacity compared to the absolute loss in type 1. There was a higher prevalence of severe hypoglycemia. This may relate to hypoglycemia unawareness that's present in these. And perhaps because of the length of follow-up or others, there wasn't evidence of microalbuminuria or diabetic retinopathy. And these Wolfram patients have had diabetes for quite a long time, 12 years at that point. So quite interesting differences. And it probably relates to the fact that some Wolfram patients may have some residual C-peptide secretion as part of this. And that's got implications for the treatment, of course, as well. And also in that paper, in the supplement, she showed very nicely that one thing perhaps we should try and do, we absolutely should do in this, is optimize glucose control. And what Dr. Raham seemed to show is by dividing the Wolfram patients up into those who managed a glycated hemoglobin less than 7.5% in old units, or more than that, those who had the better glucose control had a slower progression of their neurological complications compared to those who had a worse glucose control. And that sort of fits with what we see in the clinic, that those patients who do worse do seem to have the worst metabolic control as well. And really interestingly, she'd reported as well about patients who had acute deteriorations, neurological deteriorations and other features after metabolic stress, such as a febrile illness, general anesthetic, or a severe hypoglycemic episode. So these are really important observations that I think can be applied in clinic really for advice to families, such as making sure that they have flu vaccines every winter, for instance, and taking great care with any anesthetic requirement. So what research studies are available then at the moment? We've had there. So Dr. Sarah Gladstone from the Snow Foundation of North America has put together this really nice schematic in 2019, which is now updated for September 2020, looking at the different initiatives that she was able to pull together around the world. And you can see on the left-hand side, the first efforts are really to try and prevent progression of the syndrome. The next group then really is actually to try and protect cells and hopefully regrow damaged tissue. And then the bottom one down here is to try and replace pathogenic genes and gene therapy eventually as well. We start at the top, ER calcium stabilizers. I referred to calcium channel blockers in the Pathophysiology. So Professor Fumi Arano and his colleagues in the St. Louis clinic in Washington, University of Washington, St. Louis, I should say, did a phase 1 clinical trial of dantrolene, exposing about 26 children and young people to dantrolene with Wolfram syndrome, open label and a single arm study. And they were exposed to it for somewhere over 6 months at that point, up to therapeutic doses. I haven't seen the report yet, but Fumi's presented it a number of times. It did seem to show that overall dantrolene was safe in children and young people with Wolfram syndrome. There weren't any excessive side effects. However, there wasn't any clear improvement in either diabetes control or in change in visual function. So there didn't appear to be any benefit in terms of control of either the metabolic or the neurological features of the condition. And I believe at the moment he's planning an extension study and perhaps a phase 2 trial of this as well, just to follow patients up, because on a short follow-up period, it's very difficult to see if there's an effect on neurodegeneration. I'm also aware that he's looking at second and third generation calcium stabilizers that might be more specific on this, and he's trying to develop these as well. I'm not so sure about Professor Benjamin Delprat's investigations at the moment that he's got, so I can't talk to those as well. Molecular chaperones, I do know that the Arano lab is now working with a company to develop a potential molecular chaperone that will actually stabilize the endoplasmic reticulum and work as a small chemical chaperone to try and abate the unfolded protein response. I'll come back to our study at the moment, which is sodium valproate, which is acting as a cell cycle stabilizer, and I'll talk a bit more about that in a moment. GLP-1 receptor agonists and liraglutide is a very interesting area at the moment, particularly because of work done in a rat model of Wolfram syndrome by groups in Estonia, and also latterly by Professor Knopp, has taken an interest from human studies in Brussels as well. The work by Maria Platz and Anton Terasmar and others exposed a rat model of Wolfram to liraglutide and has demonstrated very nicely improvements in glucose control in the diabetes, and also increased secretion of C-peptide in those patients. These rats have now been followed up into older age, and they're now looking to see if there's any evidence of slowing the progression of the neurodegeneration at the moment. But it's not yet clear if that's going to be the case. The underlying mechanism of GLP-1 receptor agonists probably is amelioration of endoplasmic reticulum stress, and it's being proposed as a treatment for ER stress in other types of diabetes as well. And in theory, it ought to work as a good treatment for the diabetes in Wolfram, because there probably is some residual C-peptide secretions, some beta cell function there as well. So liraglutide is certainly receiving a lot of interest at the moment to treat the diabetes aspect of Wolfram syndrome, but it's really not clear at all yet whether it's going to have any effect on the longer term neurodegeneration of Wolfram syndrome. Okay, ongoing studies there for regenerative are MANF, which is mannose binding filament protein, and this is part of the coating of axons in the central nervous system and seems to be a mark of this, and Professor Arano is looking potentially at a trial of this. And then further down there are proposals to do gene therapy in patients, particularly to try and treat the optic atrophy, although there have been some concerns because of gene therapy treatments in the eye recently and potential side effects on vision there as well. So those studies are a little bit further behind. So I said I'd talk a bit more about the valproate trial because that's ongoing and that's working at the moment. This is funded by the Medical Research Council, and it came out of the EuroWAB, European Registry for Rare Diabetes Syndromes originally. It's a phase 2, so a pivotal clinical trial, to look at the effectiveness of sodium valproate to try and stabilize the neurodegeneration in Wolfram syndrome. It's in children and adults, and the primary aim is to try and see whether it has an effect on a biomarker of neurodegeneration, which in this case is visual acuity. And then secondary, to assess the safety and tolerability, and to look at the effect on other complications, including diabetes, bladder, and of course quality of life. So the study is powered to see whether or not we can slow the progression in the visual acuity loss by about 60% over that time. The study opened in Birmingham in January 2019, and now has also opened on the adult site as well. It's recruited 14 patients so far. It's now open in France, and it's open in Spain, and the first Spanish patient's been approached, and it's about to open in Poland as well. So it's really nice that this trial is still progressing despite COVID at the moment. Why sodium valproate? Well, it's been around for 50 or 60 years. There's been a lot of publications in PubMed about this. It's clearly a well-known anti-epileptic treatment with a clear safety profile that we know about. It crosses the blood-brain barrier, so it gets to where we want it to work, and it seems to work on a number of different pathways, including altering neuronal signaling, histone deacetylator, and in our particular case, it seems to increase the expression of partially functioning Wolfram protein if it's available. It increases the expression of the BIP molecular chaperone from the endoplasmic reticulum stress pathway. And it also increases the expression of a cell cycle regulator, P21-CYP, which holds cells in their stabilization phase and seems to stop them going into apoptosis, allowing them time to try and repair some of the damage and modify themselves in the case of endoplasmic reticulum stress. Clearly, it's got side effects, and the one that we're all concerned about is effects on the unborn baby. So any patients taking part in this have to be part of a pregnancy prevention program, so that this minimizes as much as possible any risk about getting pregnant as part of this. Work done by Professor Mark Pashonsky and others in ESTEM shows some quite promising effects of sodium valproate in neuronal stem cells and end-stage neurons from patients with Wolfram syndrome. So the endpoint of this was chosen as visual acuity, really because this is the thing that most families and patients seem to be concerned about, obviously the loss of vision. And this is data very kindly shared with me courtesy of Professor Tamara Hershey in St. Louis Wolfram Clinic in University of Washington, St. Louis. On the x-axis, you can see the age of patients in years, and on the y-axis, you can see visual acuity. And visual acuity of 0 would be 20/20 vision, and a visual acuity of 2 would be vision where you can just count fingers only. And each coloured line on here represents the progressive loss of visual acuity in individual patients attending the Wolfram Clinic in St. Louis. So you can see that there's a lot of inter-patient variability. Some patients progressing quite fast. This one here, for instance, actually had cataracts, and there was an improvement after the cataracts were removed. But you can see you can draw a regression line through these and see that there's a rate of progression of that sort of figure, that amount per year. The clinical trial of valproate is powered to detect a 60% improvement if we can slow that progression, so that somebody, hopefully, somebody who's losing their vision at the age of 10, for instance, here, if this treatment works, it'll be slowed so that they would only get to that same vision point when they get to about 18. So hopefully we might give another 6 to 8 years of useful vision. And we hope, I suppose, that this buys time while other regenerative therapies might be able to be to come online to see. So that's pretty much what I wanted to cover in about 40 minutes or so. There is good information in terms of diagnostic testing on the excellent website of diabetesgenes.org, run by Professor Andrew Hattersley and others. And there's information on the UK rare disease services, including the Wolfram Clinic, on the Birmingham Women's and Children's Hospital site here that you can see. And then on the Euroweb website, although it's a bit out of date at the moment, there are patient information leaflets and also some healthcare professional guidelines about management of this. The guides to health professionals were put together now in about 2014 and need revising and updating. So if anybody on the call is interested in taking part in a group to revise those guidelines, please do get in touch, because I think the family support groups would be very keen to get these updated and hopefully published as well. So do please say if you're interested in pulling together a group to do that. And that's really the lot I wanted to say. I think finally, a big thank you to our collaborators on the left-hand side in the clinical trial who are delivering this in the UK. In the centre, our international collaborators, our colleagues in America and our colleagues in Europe who've done so much of the work of this over the last 10 or 15 years we have here. Patient support groups and charities on the right-hand side who've really been instrumental in this, including the I Hope Foundation, which should be on here as well, and then academic institutions along the bottom as well. Thank you very much.